We're talking with Dr. Keith Woodward, board-certified radiologist, board-certified in neurointerventional radiology. We're going to learn about what that is and how it can prevent somebody from having problems of a stroke in their recovery. Keith, welcome to the Dr. Bob Show.
Thank you so much for having me.
First of all, what is a stroke?
A stroke can be of two types. A blood vessel that takes blood up and oxygen to the brain can either be blocked, so that part of the brain can't get oxygen. That's what we call an ischemic stroke. Or it can be ruptured and bleeding, and that's what we call a hemorrhagic stroke.
So we've got an ischemic and a hemorrhagic. Are they easy to differentiate?
They're very easy to differentiate. A basic CAT scan in any emergency room will tell the doctor quickly if it's ischemic or hemorrhagic.
And what are the symptoms? Are there any keys to, I think I'm having a stroke, or I think my neighbor's having a stroke? What are some of the symptoms?
We talk about FAST as a mnemonic to remember. So FAST, if you see someone who has facial weakness, weakness in one arm, or if they have problems with their speech, then T, FAST, face, arm, speech, time is brain. So the T is time. Call 911 as soon as you see any of those symptoms so that we can quickly react to that.
So what does the face look like? If somebody has a stroke, what happens with the face?
Typically you'll see asymmetry or weakness on one side. That's the most common thing.
Is it usually the one side of the mouth will droop or the other when you smile? So you tell somebody to smile, or let me see your teeth, and one side will droop.
Correct, or open your eyes and you can't open one eye as well, correct.
How about the weakness in the arm? How weak does that get?
It can be anything from completely unable to move that arm, or if you ask them to hold up their arms, they can't move it, or it may be something where they can only get it partially up. It may be partially weakened.
It must be interesting to see the different variants on that. In speech, what's it sound like?
We see two different things, typically slurring of the words, where these words are all slurred and they're hard to understand, but they're the right words. And another word we call is called aphasia, which means they can't say the right words. So the words make sense, but they don't go together and they're not the right words.
So if you see those symptoms, you call 911?
Call 911.
Get to the emergency room right away. Does the ambulance or the emergency medical transportation, can they do anything on the way to the hospital to help the doctor?
They can determine if it's what we call a large vessel stroke or a bad stroke. And if they see in the field it's a bad stroke, they will take the patient directly to a comprehensive stroke center. And that's kind of a big fancy word for a hospital that does all the things that neurointerventionalists do.
Neurointerventionalists, and we're going to get into that in just a minute. So when somebody gets to the hospital, is there anything you have to do to make the diagnosis? Yep, this is a stroke.
We do that CT we just talked about to see if there's any bleeding. Is it a hemorrhagic or an ischemic stroke? Because those are treated very differently. And if we don't see any bleeding, we do what's called a CTA, CT angiography. And we do it right after the CT, and it shows us the blood flow to the brain. And is there a blockage? We can see that blockage.
Does that give you a good visual interpretation? You can see the blood going up into the carotid artery and then to the brain and see right where it stops?
So yeah, so before you could just see the vessels, but now you can actually see how fast the blood's flowing. So if there's a partially blocked artery, I can see there's a color map that shows, hey, there's not enough blood over here on the right side of the brain. It's too slow. Something's blocking that blood vessel.
Does it give you any other information, a CTA, the CT angiography, the blood vessel, the CAT scan of the blood vessel? Give you any other information about how much of the brain is involved, or how old the clot is, or anything like that?
It does. So the perfusion shows not only what part of the brain is not getting enough oxygen, but it can also estimate how much of the brain is permanently damaged versus how much is treatable or salvageable. And that's what I want to see. I want to see somebody who comes in who the brain's not getting enough oxygen, but it's all still alive. So if I go in there and open that up, they'll get much, much better.
So if you go in there and open it up, what you're going to do then is allow the blood to begin to flow again.
That's right.
And so the brain begins to get the oxygen that it needs. And the brain uses more oxygen than most of the body.
Any other part of the body, that's right.
So when you look at the CTA, can you pretty much get a good idea of, I think this is the perfect candidate, or
yes,
is it going to be difficult, or is there ever two places that are blocked? Or
sure. Sometimes there are two places. What it not only tells me if there is a blockage, but I can see all of the blood vessels from the heart all the way up. So I know what I need to do to get there, which tools I need to get there, how many curves I have to work around. And so it kind of gives me a roadmap of what I need to do next.
To me, that's just very, very exciting to listen to you talk about, planning to really save this person from a dysfunctional life, maybe even death, and and get it where they can become active and productive again. So that's what an interventional radiologist, tell me what interventional neuroradiologist is.
So an interventional radiologist, and when I moved to Knoxville, I was an interventional radiologist trained to do procedures inside the blood vessels of the arms, the legs, the kidneys, the liver. And so interventional radiologists are trained to use cameras, imaging, radiology stuff to get little catheters up inside vessels into the organs and work on them. When I came here, there were no neurointerventionalists in Knoxville.
There were none?
None. And it struck me as odd. One day I was watching the news and there was a football player in Maryville, and I don't know who he was. I'd like to meet him someday, but he had a stroke on the field. He passed out on the field. And they had to transfer him out of Knoxville to be treated because he had an abnormality with his blood vessels in the brain. And I thought, why is there no one here in Knoxville that can do this? And so I left Knoxville and went back and got the additional training to be the neurointerventional radiologist. I was the first neurointerventional radiologist in Knoxville back in 2004. And that's someone who's trained to work on the blood vessels inside the brain. And it takes extra training because of the challenges that are presented just to get up into the brain.
I would think that'd be very, very, very thrilling and exciting to do. It sounds dramatic and storybook, but it's also one that requires a lot of skill, a lot of preparation. When you get in the neck, what do you do? And how do you get in the neck? How do you go after that clot?
So let's say someone's got a clot, they're having that ischemic stroke, the brain's not getting enough oxygen. I make the determination what's the easiest way to get there. Sometimes it's through the wrist, sometimes it's through the groin, but I put a very small needle, numb up that skin, and take a little catheter and I thread it in. And using an x-ray, I advance it all the way up using little wires that I can turn and catheters that have different shapes. When I look at that CTA, I decide which shape catheter I need, and I can pick the right tool to get up there into the neck, and then from there all the way up behind the eye and up into the very large distal parts of the brain to pull that clot out.
So you can actually go up along, must be very, very small?
They're tiny. So we can work on vessels that are 1-2 millimeters in size.
With the help of the x-ray, is it easy to know where you are? I guess that you can see the catheter as it's going up?
It is today, Bob. When I started, it was not. So the machines now give me a 3D map, and as I move that machine around, the pictures of the vessels turn on the screen. It shows me exactly where my catheter is inside that brain.
It's getting too easy.
It's not too easy, but it's getting a lot easier.
So when you get to the point where, oh, here we are, here's where the obstruction is, here's where the clot is, how does that catheter remove the clot?
So I have two ways to get it out. One's basically like a little vacuum. It's when I get that little catheter up there, I hook it up to a suction, and a clot gets stuck on the end of it, and I pull it out. And it's interesting, when I start to pull, I can feel it. It's almost like when you're fishing, when you know you have something on the line. When I start to pull it, I can feel it starts to vibrate. I know I've got a clot there, and I pull it out, and the clot will be sitting right there on the catheter.
What does that clot feel like when you get it out and you're examining it?
Sometimes it's like a jello type material, but sometimes it can be a hard rock. It depends on where it came from. It can come from the neck, they can come from the heart, they can come from other places in the body.
When that happens, does the patient recognize what's happened?
When they pull the clot out, they typically don't know there's a change, but when I ask them something, they'll realize all of a sudden they can do something. For example, if they couldn't lift their arm, I'll say lift their arm, and they'll go, oh wow, I can move my arm now, and they just realize at that moment that everything's going back to normal.
That must be amazing to see. I'm going to ask you about another story when we come back, and we'll learn more about intravascular thrombectomy, simply going up into the vessel simply and finding the clot and removing that. And we've talked about suction. We'll talk about the other way to do it when we come back.